Without any further ado, would like to introduce the 2015 lecturer for the W. Montague Cobb Symposium, Joan Reede, Dean for Diversity and Community Partnership at Harvard.
Good afternoon. It is good to be in a place where you can say good afternoon and people respond. Sometimes at Harvard, people don't quite know what to do when you say that, and they've not been trained in the call and response. So thank you very, very much. I'm so proud to be here. This is such an important part of the NMA and the Cobb Institute, and deeply honored. Randall is correct, as is Cato, that I contacted them because I was really interested in this topic of leadership, but in having you hear from the young leaders and the people who are in the pipeline. And as part of it, I was told that I needed to give a lecture that led into it. So deeply honored for that, but also deeply honored that I'll be a part of you hearing their voices. Where I want to begin is to talk about this concept of leadership and the importance of diversity in this leadership, but to think about why diversity is important. And I'm talking about three things here, about how diversity helps us to realize our values, how it helps us to address complex issues and problems that we're facing, and also how it enhances the viability, ensures the viability of our institutions. And when I talk about these realizing the values, these issues around equity, around justice, around inclusion, go back. They are part of the foundation of medicine. So if you go back to the Hippocratic Oath, in the Hippocratic Oath they talk about us as members of a society and our obligations to all patients. That's 5 BC. If you move forward to the Declaration of Geneva in 1948, they talk about, I will not permit consideration of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing, or any other factor to intervene between my duty and my patient. Fundamental to who we are as professionals. If you look at the Belmont Report from 1979, which really followed an understanding of the transgressions of Tuskegee, and speaks to what we need to do and how we need to have safeguards within our research enterprise. It has three major components. One is about respect for persons. A second is about this beneficence and doing no harm or minimizing risk. But the third is about justice. And it states that ensuring reasonable, non-exploitative, and well-considered procedures are administered fairly and equally. Again, these issues around equity and ensuring that all parts of our population are able to get the benefits from the research that we do. And more recently, the Charter of Medical Professionalism from the American Board of Internal Medicine, 2002, talked about three fundamental principles in medicine: patient welfare, patient autonomy, and this principle of social justice. This idea about justice and being equitable also shows up in the Institute of Medicine Crossing the Quality Chasm report from 2001, where it talks about healthcare systems and what needs to be in place if we're going to have an excellence in our healthcare system. They talk about healthcare systems need to be safe and effective and patient-centered, timely and efficient, but also equitable. So when I turn to my own institution, how does this show up? I've been doing diversity at Harvard Medical School or diversity work for more than 25 years. And a few years ago, we added diversity, or the concept of diversity, to the mission statement of Harvard. So a change from doing diversity, which is a nice thing to do, to doing work around diversity and diversity inclusion is fundamental because it's part of the mission of our school. And it's been further described and defined by our dean of our school, who's moved it to a place now where he states that Harvard cannot achieve excellence in teaching, research, and service unless there is diversity. That Harvard cannot be a world leader unless there is diversity. And that diversity is required. Diversity of individuals must be involved if we are to change the culture of Harvard such that it can move forward in the future. So when we talk about this issue of diversity, oftentimes we talk about these traditional forms of race, ethnicity, gender, more recently sexual orientation or ability and disability. But I want to put forward that there are multiple dimensions of diversity, of culture, of the environments in which we've grown up, our values and our preferences, the relationships and the networks that we have, and that all of us bring all of these components of diversity to the table. For me, as an African-American woman, I find it fascinating because sometimes you feel this push and pull. You go into meetings and you have to figure out today, am I representing the blacks in the room or am I representing the women? Which part of me? And this concept of intersectionality, that I am all of this, is not addressed. Important as we talk about this holistic admissions, because we've addressed some of this with our medical students in this concept of holistic admissions, and it's more than a number, it's more than a grade, it's more than a score. And now we're starting to talk about this in graduate medical education as we're looking at our training programs and the debacle that's out there in terms of our residency programs, looking at a score and thinking that that can determine who can be the best resident. So we're talking about holistic admissions for graduate medical education. What we're not doing is understanding that it's not just about entry. How can these individuals come into our organizations and bring their authentic and whole selves so that when they arrive, the institution is able to gain the benefit of all that they are. For me, it's when I stand in a room and they'll say, you know, Joan, this is wonderful, you know diversity. And I'm thinking, am I a pediatrician? And did I do child psychiatry? And do I have 4 other degrees? Maybe I know some other things too. And they put us in boxes, and then sometimes we allow them to put us in boxes. They don't get the full benefit of what we have to bring, and we don't get the full benefit of what we're able to offer. Diversity in addressing complex issues, and many of you know the work of Scott Page, and he talks about diversity as we're dealing with these complex issues in our society, and this toolbox that we can unpack, and this bringing together this diversity of perspectives, of interpretations, of heuristics, or how we solve problems, and the models we build are required if we are to address complicated problems and issues, diversity of thought. And if we think about the complex issues we're suffering or dealing with today, as we think about research and building diverse research teams, as we think about research, and are we including all populations? Are women there? Are people of color there? As we think about diversity in education and training and the serious issues that we're addressing today, as we expand our medical schools, who is coming into our medical school class? To what extent does it represent our population? To what extent are opportunities available to those of us that I call, like myself, the multi-generational Americans, the Americans whose history includes slavery in their family? Are we a part of this process? Are we being left out of the process? Are we training and educating students and residents who are going to be able to deal with the diverse populations that we have? As we think about patient care and cultural competence and our patients getting the care that they need and quality care, health outcomes and health disparities and how that's disparate across different populations, and our real societal obligation in a pluralistic society to serve all, again going back to our values. Complex issues that are mentioned in multiple parts of this meeting. You know, we've been going down this road in medicine and medical education, and times are changing. It's a great time of change. For the road ahead, I'd like to think of it as closed for repairs. The old will no longer work. As we think about changing delivery systems, who ever thought we'd be talking about Walgreens and CVS delivering health care? Changes in the practice of medicine as we talk about personalized medicine, but personalized medicine for whom and how. As we talk about things such as ICD-10 and changes that are coming down the pike in just a few months from now, and how prepared are we for those changes? Changes that are going to be about changing the measures of how we're performed, and we don't have the systems in place. Changes in the relationships among the players, the stakeholders in the system. So we think about our federal government and ACA, part of a conversation earlier today. our states and those who brought it on and haven't brought it on, our local governments. When I think about the city of Boston, where the mayor and the Public Health Commission is asking our academic health centers, what are you doing to eliminate disparities in our community? The local governments are weighing in. Insurers, people who are in the exchanges, our healthcare organizations and the safety net and their relationship with government as dish payments and uncompensated care are going away in many places. Our safety net organizations that are themselves changing. So I was recently reading about Charity Hospital, Charity reopening with a new name and an expanded role, and will it take care of the same population? What is going to happen to those individuals? Providers are changing, and this interprofessionalism, something that's important, but what is our role as physicians? Patients having new roles and new places, and patients who were once denied access, having access, but not being able to find a provider for that access. Changing times. So for me, this is an exciting time. This is a time when new systems are going to have to be built, and how can we be at the table? Not after everything's been determined, but at the table deciding what needs to be determined and how resources are going to be allocated. Viability. Our institutions have human capital. We bring human capital, social capital, intellectual capital. And what happens when you don't recognize the full wealth of resources that we represent and that's left behind? And our organizations cannot afford to do that. As we talk about time of scarce resources, is it efficient or effective to not take advantage of the full capacity that we have to really move our organizations towards achieving their missions? And then the changing demographics. You know, in 2012, there were 25 states in DC where the population was more than 40% minority. There were 13 states in DC where for the greater than 50% of the children under age 5 were minority. We know that by 2050, 2060, over half of our population will be minority. If we look at these issues and people talking about immigration, 13% of our population were born elsewhere. As we move forward to mid-century, it's going towards 19%. We sort of talk about these immigrants as though they're not a part of the fabric of the United States. The immigrant children are the fastest growing population. 25% of the children living in our country live in an immigrant family. And what we need to recognize is that 88% of those children are US citizens. So as we talk about them as being different, they are us. We are them. US physicians, long-term underrepresentation of Blacks, Hispanics, Alaska Natives, Native Hawaiians, Native Americans. Academic medicine, similarly, lack of representation, poor representation. I've been doing this work for a very long time. For me, as I see this percentage here, the most striking thing for me is that this percentage made a huge jump after the Greta v. Bollinger case with the University of Michigan, because they changed definitions. And it reminds us of the fact that as we talk about these issues, we're talking about social constructs. And there's all sorts of things you can do if you change a definition. But the truth of the matter is there's not enough of us there. At the same time, in this particular meeting, it has been amazing to see the pioneers, the individuals who, despite these low numbers, have set a stage for the rest of us to be here. The leaders, as you saw the Surgeon Generals, and you hear about Regina Benjamin, you see individuals such as David Satcher. You see individuals who've held roles such as David Satcher, Lou Sullivan, Dean Gracia was here from the Office for Minority Health. You see leaders in places such foundations that we never saw before. You have Risa Lavisa More at Robert Wood Johnson, and Bob Ross, who's at California Endowment, Garth Graham, who sits here, who's with Aetna Foundation. Major changes in terms of people in leadership positions. If we look at government and NIH, we have individuals who are now directors of institutes. Early on, I never thought I would see a director of an NIH institute in my life who would be leading those things, particularly people I went to college with. You know, I look at Griff and I'm like, my goodness, that's not what I thought was going to happen when we were at that party. But they're in leadership. I look at people like Vivian Pinn, who have stayed the course for so very long, who showed us how to be a leader in the academy, who showed us how to be a leader in government, who showed us how to be a leader in this association, and has mentored so many of us, opened doors for us to be where we are now. These leaders have made strong strides and great changes, but I ask you to think about who is coming behind. Who is the next generation? So I'm going to give you a small example because I find this striking, and there's a wonderful forum that's going to be offered tomorrow that really deals with the pipeline, and particularly around African American, about black men, black boys, critically important. But it's not just that end of the spectrum where there's a problem, at the other side there's a problem. So here, these are from some AAMC data that show 2004 and 2014 faculty numbers. So there has been an increase. In a 10-year period, there is 150 more black male faculty. And there is 828 more female faculty. Seems quite inadequate when there are 17 more accredited US medical schools. If you look at the female faculty, you can say, well, there's an increase of about 50%, but now we're at 161 female full professors. So if you distribute them across the United States, we have just about enough for one female full professor per medical school. This is a problem. And if you look at what's happening to our black men, we've gone from 278 to 360 full professors. Sounds good, but look at the pipeline behind it. And associate professors over a 10-year period, only 16 more black associate professors. That's the pipeline towards leadership, a critical problem. So it's not just this idea of entry and getting people in. Are we retaining them? Are we advancing them? Are they moving forward? These are individuals who are pioneers. Think about yourselves. Think about the people who've come before. Pioneers who need to be more competent on the job, be able to fit into the organization, make others feel comfortable with your difference, deal with people's preconceptions, questioning whether or not we can do the job or why we're there, and then asking us to serve on every kind of committee possible so there can be representation, and then not count that service towards advancement or promotion or really helping the institution to be successful. Being involved in recruiting and outreach. Pioneers have paved the way for people like myself to be here today. But what's the toll on those individuals? And we need to move beyond pioneers. What happens to individuals in our organizations when they're faced with these kinds of challenges and structures that are not only not welcoming, but structures that are biased? This is from some literature from England, some qualitative studies looking at the legal profession and women in the legal profession, but it pertains here. Individuals who enter an organization and become a part of that organization in ways that perpetuate the problems that we've had, and then those few individuals like the ones I've mentioned who's transformed them. Think about the push to assimilate, to say, I want to dress like you, I want to look like you, I want to have the same hobbies as you. How we're asked to compromise on our priorities between our work and our personal life. The playing the game and the stress of playing the game of always trying to figure out ways, how can I be visible? How can I be noticed? How can I prove that I have value versus the organization understanding and accepting the fact that I have value? The location relocate. Think about the individuals that say, well, it's not working here, I'll try over there. And they just keep moving because that full diversity, that wealth of what they bring is not recognized by the organization. And then the people who leave. And I think some of what we see in those data that I showed in terms of black faculty is because people have left. They're not willing to stay the course because it is so hard. And then we have those who can transform. So what are some of these barriers to our achieving diversity? Some of them are at the individual level. There's constraints that we have ourselves. It's the resilience to stay the course and to deal with these issues. But are we adequately prepared, and do we have the opportunities put before us, and do we have the resources to be successful? Some of it's our society, the politics, the economics, the culture that we reside in. This is not a minority-friendly or a diversity-friendly society. You know, it's interesting. I remember in my institution, for some of the people who talked to me after Obama was elected president and came to me and said, you know, isn't this wonderful, because now as a nation we've arrived. And these issues around diversity and minorities are resolved, okay? He was elected president, but did you read what was said as he was elected president? That undergirding of bias and discrimination, of stereotyping, of resistance to change still exists. But I want to also talk about the organizations that we enter, because all too often we think about, how can I fix this person, when it's the organization and the structures of that organization, the policies of that organization are where we need to spend some of our time. So our office, my office at Harvard Medical School, is called the Office for Diversity and Inclusion, putting the words together, so that my work is not about how do I change the numbers at Harvard, although we've changed the numbers, but how do I include diversity across all aspects of the organization. All too often in our institutions, we have our organization, here's our mission, here's our goals, here's how we do our business as we strive in academic medicine towards this excellence in research and teaching and service. And then we have our diversity programs off to the side. They're not embedded. They're not part of the structure. And all too often when we look at them, the only thing we count is, did the numbers go up or down? And think about your institutions that celebrate an increase in number. When someone says, you know, we have 100% more black faculty than we had last year. And the next question you should ask is, well, how many did you have last year? Because they went from 2 to 4, okay? And when you look at the 4, you don't even know if they include the 2 that were there last year, okay? So we have been forced into this place where we're looking at numbers that we don't really understand what's going on within our organization and don't know where to pinpoint interventions. If you think about the organizations and thinking about them moving along a continuum from early stages where they talk about these exclusive or passive clubs, these clubs that are really based around the founders and their views and their values, and places where it's sort of, if you have to fit in that one culture or one style to exist, when you try to bring diversity into that place, they don't get it. They don't even know why you're there. And moving along this continuum towards the pioneers that I spoke of, to having a critical mass, to actually moving towards a place that's not just welcoming, but where diversity is included. A transformed organization that's able to recognize that full array of benefits that can accrue from having diversity. So how does diversity move in so that it is embedded, it's included, it becomes a part of the structure of the organization? Our programs become part of a structure of an organization. They're not viewed as you talk here about pipeline programs and these other kinds of things, they're not viewed as something that's nice that you do on the side, but organizations understand that they are imperative for the viability of our profession. And then how do we build the tools so that we can monitor what's going on and move beyond just counting numbers? So I'll just give you a little bit of the data. I have a research team in my office, and these are the names of my sort of research individuals who do much of this work. And what we've started to understand is that connections and how we're connected really matter. That all too often we feel isolated in our institutions and organizations, and how we are connected has an impact on our productivity, it has an impact on our advancement, and it has an impact on our retention. So one of the measures we use is something called REACH. It's looking at co-authors within an organization and the co-authors of co-authors. So it's starting to see, who do you work with, how are you connected, how visible are you within the organization. As we look at this sort of issue, what we find, and this is within Harvard, and this work was done there because it's one of the few places where you have 12,000 faculty in one institution, so that the N is not a problem. Think about all the studies that we would tell you more about what's happened with minorities, but there's not enough of an N in the cell size, so I'm only going to tell you what happens with the whites, right? So this concept of reach or the connections is lower for women than it is for men, women in the blue, across all age groups. It's lower for blacks, Hispanics, and Native Americans than it is for whites and Asians across all age groups. So this connectivity. But what did we find? Does it make a difference? We looked over a period of 4 years and said, does it matter that our reach, our connection is less in our institution? And what we found, if you divided our faculty into quartiles, is those in the highest quartile at the instructor level are 3 times more likely to be promoted. That's if you take in the number of publications and the H index and where they trained and all of these other kinds of things, all of your demographic variables, how they're connected within the organization makes a difference in terms of the advance. 3 times more likely from instructor to assistant, 2 times more likely from assistant to associate professor. Connections matter, and we are not as connected. When we looked at attrition and leaving the organization, those with the highest connections, 25% less likely to leave. So as we start thinking about programs and what we need to do within our organizations, how are the individuals actually included within the organization? A little bit about programs, and I'm only going to talk about 2 of them here from our office, because what I'm often told is this work is too hard, or it costs too much money, or you can't do it. And so I'm going to give you 2 examples. One relates to a young woman, a resident, I think was a radiology resident, who spoke yesterday and talked about opportunities to explore different kinds of career paths. And here I want to talk about a visiting clerkship program. And then the second thing I'm going to talk about is a fellowship program that's for training leaders, called the Commonwealth Fund Mungan Fellowship in Minority Health Policy. Both of these programs are built on a set of principles that we have, that we look at careers as moving from one part of the country to the other. Lots of ways to get there, lots of paths, lots of stops along the way. There's not one right course, and how do we take that into consideration? How do we have a continuity of efforts as we think about the work that's going to be coming out of the NMA and AAMC and others who are partnering around our young black men and moving them into the pipeline? That's not enough. It doesn't just stop with, can we get them in medical school? Can you get them in residency? Can you move them in other positions? It is a continuum of efforts, and given that I'm a pediatrician, it's a continuum that sort of starts in utero, but that's a different kind of issue. Consistency of effort. We start programs and we end them. The funding isn't there, so we just start and stop, start and stop. And we expect communities to stay with us. This importance of collaboration across institutions. Again, this issue of diversity, diversity of thought, diversity of perspectives, diversity of access coming to bear. Doing things that are different, not doing the same old thing, being creative. Communicating for me as we do this work, and understanding that the generations today communicate in a very, very different way. So I'm much better than I used to be, but a couple of years ago, I remember I sent my daughter a text, and what she wrote back to me was, "Who thought you could figure it out?" Okay? So they communicate in a very different way. As we're trying to create change and these new leaders and bring people in, we're going to have to also change what we do. Consideration of these multiple dimensions of diversity and not asking people to decide which box you want to be in today, and a consistent commitment. So as we think about this commitment, this is a visiting clerkship program. And early on in my tenure at Harvard, looked at when minority faculty decided they wanted to go in academic medicine, and a third was in college, a third in medical school, and a third post-medical school. But that transition between medical school and residency was critically important in terms of providing exposures. And so started a program where we support students being able to come to Harvard and do rotations in any area that they like, where they're provided mentors, where they're given the funding, because our students, given their debt load, cannot afford to pay for housing in Boston and transportation to Boston and for housing where they are. What you see here is that over 1,000 students have come through the program. They've come from multiple medical schools, and the reason you see 151, greater than 151, is because our medical schools keep changing their names and their affiliations. That consistently more than 10% every year match to our programs at Harvard, but many have ended up on faculty. So again, this continuity, this continuum, this effort that goes on. When I first started this, I remember some of the hospital presidents and others coming to me saying, we've been doing this for 5 years, Joan, and I don't see faculty. And I'm saying, you were talking about medical students. It takes a while to get there. Continuity of effort. The second program is the Commonwealth Fund Fellowship in Minority Health Policy, really born out of the Commonwealth Fund and Karen Davis and her participation in healthcare reform pre-Obamacare. And what she talked about was coming to these tables where they would be talking about the social determinants or vulnerable populations and looking around the table, and the populations that they were talking about were not there. There wasn't representation, and came back to me and said, is there a need for diversity leadership around public health and health policy? And this is a program that was formed with considerable consultation and input from multiple individuals, from Marilyn Gaston to David Satcher and many, many others. But over that time, you can see the vast majority have been women. It's a program where we pay for a degree, an MPH or an MPA. It's a program that has these sort of skill sets that you would think that you would need if you were going to move into a leadership position. It's a program that also says as you move into a leadership position, you have to be able to work with community, where community is, to have this respect for community and community guidance, that it has to be about advocacy, and it has to be about creating change. These are some of the things that you read about in the leadership books, and they're important, but there's another component of this that I think is equally important. Our younger faculty, our fellows, our young physicians need sponsors. They need people who are willing to open doors and to vouch for them. They need mentors and networks, developmental networks across multiple disciplines and in multiple spaces. They need a community of support. All too often, they're entering spaces where they're isolated. If I think about myself and my career, I think about the individuals now who I turn to that I consider my supports, the people that I call on as I'm dealing with the challenges within my organization, when I have my self-doubt, when people are saying things that I just don't get. I need safe spaces to have conversations about, do you see just what happened? Safe spaces, as I think about our fellows and we think about Black Lives Matter and the deaths, safe spaces where we could come together and sit in a room and be able to cry as women who thought about our brothers and our children, and for me, my grandchildren. Where can you have those conversations? Because we are dealing with our personal lives as we deal with our careers and we deal with our organizations. They need resources, real resources, not pat on the back, this is nice, but real resources. And they need to be challenged to understand that they can do more and be more. So what has come out of this program? This is one program. 94% serve on national or federal committees, 73% invited for interviews, TV, radio. The majority have published, all are engaged in policy or public health or research or service around vulnerable and minority populations. And 78% have academic appointments in medical schools or School of Public Health. So these are individuals such as LaQuandra and Alden that you'll hear from Joe Batencourt, who's one of the Cobb Fellows, from some of the other fellows here, such as Kim. These are individuals who have moved into spaces where they've made a difference. The head of the Indian Health Service, the Commissioner of Health from Massachusetts, placing people in positions, excuse me, where they can create change. So as they do this, so they're moving into these same organizations that are not necessarily ready for them, that are along this continuum from these exclusive organizations that are sort of saying, why are you here, to the organizations that are saying, isn't it wonderful that you are going to be the first? But then that means you're a pioneer, and what does it mean to you, and does the organization understand it? And they need more than one pioneer. where there starts to be a critical mass, but how do you build on that critical mass, and how can the organization use that information, that knowledge, that diversity in the critical mass builds, and how can it push itself further as it moves down the continuum towards being inclusive. So what I say is the time is now and the choice is ours, and borrowing from Gandhi, we must become the change we wish to see in the world. That this is not the time to wait for others to create leaders. It's up to us to create the leaders, to support the youth that are coming behind. And so when I call them youth, you understand what age bracket I'm in, because youth begins at an early age, but it continues on up. But how do we take care of those who are coming behind? How can we serve as mentors? How can we serve as sponsors? When they knock on your door, when they call you up, when they send you an email, respond, listen, connect. Connect them to your networks and help them to build their own networks of support. How do we start to understand the context, the environments in which they work, the organizational and the disciplinary context that help determine what's needed to be successful or to move ahead, and how do we build an evidence base that can challenge the beliefs and the myths about how our organizations actually function, how excellence is actually achieved, and how do we take responsibility for developing metrics that move beyond mere counting. How can we hold organizations accountable? How can we look at holding our professions accountable for diversity and advancement of diversity and leadership? How can we use our influence and our positions to make sure that those organizations that can change other organizations are doing what they should do? So for me, it's thinking about LCME and medical education, and what are the accreditation rules that they have? What are the rules and regulations, ACGME, all of those kinds of things? Where can we have a voice and be at the table to change things such that this diversity and this next generation can rise to the top? And this issue of interceding, this issue of being present and recognizing the youth that are around us. I would challenge everyone in this room, as you go back to your home institutions, to think about the 3, 4, 5 individuals who are in the pipeline who are ready to be able to be moved forward. Identify them and support them and connect with them. As your institution is going through the sorting process and selecting who should be moved forward, make sure that those names are present. Stand up for those individuals. We're at a crossroad. Our health system is changing. It's in a time of transformation. It needs to be informed by our values and the value of the people who are coming behind us, guided by a new kind of vision that is inclusive, secured by a vigilance, because sometimes we get comfortable because we think we've moved ahead, but it is so easy to slip back. Our voice must be ever present. We should be strengthened by our victories, but we need more. So moving forward, there's a call for new leaders. The real voyage of discovery consists not in seeing new lands, but in seeing with new eyes. We need new eyes. Thank you. Thank you.
Thank you very much, Dr. Reede. That was exactly filling the prescription and setting the tone for our program today. We have time for maybe 1 or 2 specific questions regarding Dr. Reede's presentation before we embark upon our panel. Dr. Bright?
There was an inordinate number of African-American men in the assistant position. Could you talk a little bit about, what are the obstacles that they might be facing in that position and the transition of moving from assistant to associate?
So I think there are a few things in here. One, I don't think we adequately understand what the obstacles are at that level. If I think about those from my own institution, it's being recognized for the work that they do. Oftentimes they're engaged in work that involves community or other kinds of research that are not recognized by their institution. Those are the individuals that are called on, can you serve on this committee or can you do this or that? That's also not recognized by our institutions for advancement. And as they're being asked to do that, they're being asked to take on more patient, on a larger patient load. And as you take on this larger patient load and you do this service to the organization and community, you then don't have time for the scholarship and the other kinds of things that are needed. And as you're doing all of this, you have this burden of this bias and this system that's in place and these structures that you're always trying to overcome. They talk about, the literature talks about diversity taxes. They are ever present. They don't just all of a sudden show up at one time. They're cumulative. As these individuals are trying to work through these types of issues, they're burdened and they're tired. And oftentimes they leave. Or they say, you know, maybe this is what I'm supposed to do. Maybe I'm not supposed to be reaching. Maybe I'm not supposed to advance. Maybe I'm not supposed to continue to move forward, and they have a system around them that says that that's okay. So I think there's a lot going on. I think we need to understand it better. But as you look at those numbers, in 10 years, 150 black males, 20 years, 300, this makes no sense. I think for me, this is a dire emergency. We need to understand it better, but then we need to do something about it.
Hi, Dr. Reed. My name is Dr. Melissa Walker, and I'm standing as an alumni of your visiting clerkship program from like a few years ago. But I do want to say congratulations on 25 years and that the program truly changed my life. But on your numbers that you gave, and you were talking about the emergence of the new medical schools, I wonder if you're taking in consideration in your numbers the osteopathic schools, which are developing in enormous numbers. And having gone to osteopathic school, I know that there is a shrill minority of faculty and students in the osteopathic population. Mm-hmm. So I wanted, first question is, did you take those numbers into consideration? And then the second question, as the National Medical Association, what are we doing to try to influence the osteopathic medicine field as far as taking in minority students and faculty?
So these are data that I pulled from AAMC. So I can't tell you to what extent osteopathic, allopathic. My sense is these are allopathic numbers that you're seeing here for our U.S. medical schools. The interesting thing about diversity is it doesn't matter the field, the discipline. There is a need for more diversity. So if I want to look at osteopathic schools or allopathic schools or dentistry or nursing or any kind of profession, there is a dire need for diversity. And if we look at faculty across those professions, even more so. If you think about dentistry, it's just ridiculous. They need faculty, period. But if you think about our dental schools, we have dental schools with one or no minority faculty.
My name is Dr. Mike Lenora, past president of the National Medical Association. And I also serve as the chair of the clinical faculty at the University of California, San Francisco, and have been a full professor in that system. And everything you say is very true about how you support faculty. And there are success stories at Duke and Harvard and Connecticut and other places. But there are hundreds of schools across the country where we can't even set the table to get faculty. And I know in San Francisco, the issue of diversity seems to have completely gone away. There's nobody encouraging black faculty. They like to say they have it. And I serve on the board of the new UCSF Benioff Children's Hospital, where they have no blacks in the administration, no black who had departments at the Children's Hospital. And when you start to bring it up, it's like, oh, you know, this is like, it's not your troublemaker, but it's not an important issue. So my question, and I hope it's relevant, is how do those of us who understand that this is a shrinking the population of opportunities, how do we get this discussion back on the table, back on the agenda of many of the medical schools across this country?
So I think for me, and I think it's a good question, I think that when I think about someplace like UCSF, I am, what gives me hope in that is a Talmadge King becoming the dean of UCSF. Someone who understands these issues in a leadership position where he can make change. Yes, he was there as the chair of the Department of Medicine, but now he's the dean of the school. When I think about the work that we do within our institutions, some of the things that come to mind for me is to what extent are we using the outside resources, the community? UCSF is a wonderful example. The diversity of the student body of UCSF came about not because the administration got it. It came about because the staff at UCSF, the people who cleaned and in the kitchen said, we go on strike unless you do something. So sometimes we are trying to do so much by ourselves without engaging others and a wider community and other stakeholders in the process. To what extent are we engaging our boards of directors? When I think about Mass General Hospital and some of its movement in diversity, it made a huge difference that a member of the board of directors then sat on the committee. So as people were sort of giving their comments about how and what they were doing and how they're moving forward, you had somebody from the board of directors saying, you will do something, you will be held accountable. So board of directors, community, other kinds of places, how do we band together? How do we work with people in other institutions to make these kinds of changes? I'm not in any way saying that I think this is easy or that the battle will be over anytime soon. I consider this a part of a continuum of a civil rights battle, and we're at this point in time and the battle will move forward. Part of what I'm putting forward is how do we prepare others to be a part of this, particularly others who are in a generation who may not have the privilege of understanding from whence we came.
Let me just say this, and we're very proud of Talmadge. But the students at UCSF had the largest black student rebellion in this country in the last 10 years because of the conditions in which they felt they found themselves.
Thank you, Dr. Reed. Your visibility, for me, my name is Anne Carica. I'm a Gwali. I'm a PGY4 Med Peds at Brown, has been incredible just throughout my career. I have a question, kind of picking it back on the former question. I trained at Hopkins, trained at Meharry, training now at Brown, and I see a lot of value from the different infrastructures that I've been exposed to. And I've oftentimes, now that I'm sort of further along my career, thought about the importance of potentially doing like a sabbatical type program for majority institutions back to HBCU medical schools to understand the population of students and to really add increased value to that system as they apply for residencies throughout the country. I'm just wondering like what your thoughts are for the formation of such sort of sabbatical programs, bringing back people to HBCU medical and dental schools to sort of appreciate as faculty that generation.
So, you know, I think when I talk about this idea of collaboration, that's a part of it. When I think about the value of diversity and the outcome, if you plan to make changes in systems, to make changes in the workforce, and you leave out whole segments in that conversation, then you don't have diversity. Diversity is not just about how a Howard or a Harvard or a UCSF addresses these issues and understands and brings value to our understanding of how we move forward. It's what Morehouse brings to that conversation. It's what Drew brings to the conversation. It all has to be included. When I think about the Commonwealth Fund Fellows, part of the fellowship programs include site visits and has included site visits. And so bringing them to Atlanta and spending time at CDC and the American Cancer Society, but spending time and bringing them to Morehouse so that they can see the quality of programs, the relationship with the community, and understand the richness of what's available from those institutions so that they can move forward. no place can do it by themselves. We have to be able to collaborate. So it may be that kind of program, it may be another kind of program. When I talked about building these networks and communities that you work with, I consider Valerie Montgomery Rice on my speed dial of who I call for advice or how to partner or how to do things together. That's part of what I mean by diversity.
Excuse me, we're going to have time for only one more question, I think maybe over to the left, and we may have time with our panel for additional questions, but we need to get to the next phase of the program.
Yeah, Dr. Reede, I'm Dr. Commodore from Tampa, Florida. I really appreciated that lecture. That was one of the best I've heard. I have a question about the funding of medical schools and the residency programs, and the fact that so much of that is tied to government funding. Yet, I'm just curious, has anyone thought about tying the amount of faculty diversity to the funding that these schools receive? Because sometimes those types of initiatives can cause more change to occur than from the bottom up.
So I can't tell you on that, but I'll tell you on another part that's similar, because I've raised it in lots of meetings. I've raised it in meetings where people have said, did she just say that, and moved back away from the table so they couldn't be near me, so they wouldn't be associated with what I had to say. I think about the research funding that NIH puts out to our institutions for training individuals. While NIH is calling for more diversity, while NIH is saying that we need more leadership and development moving things forward, and institutions and labs get money and don't produce that diversity and don't have people advance and move forward. I think of that in terms of that's taxpayers' dollars, where the institutions who are getting those dollars should be held accountable for what happens to the individuals who get trained, not just the lab. So for me, it would be wonderful. I know NIH is not in charge of it. Wouldn't it be wonderful if 0.5% of the overhead that the institution gets is related to diversity and faculty development? You know, our institutions, they don't respond to a lot of things, but they respond to money.
Absolutely.
And if somebody said part of your overhead is dependent upon how you perform and what happens in this space, they would listen differently. The labs and the professors, I mean, the other part for me, because I'm going to give you these are my pet peeves. These are my things that, you know, you go home at night and you say, if I could just twitch this a little bit. Institutions, for anybody here that's done the grants for the feds and the other kinds of things, and they talk, there's a whole part about the institution and the environment. And you know how many PCRs and other kind of machines and all this other stuff, there's nothing in there that requires you to tell about the environment for how you support your faculty or the career development. And what is the environment around diversity? 1 or 2 lines in there would require something to be written. I can tell you the labs and the faculty who are not paying attention to that, if they thought that some of their funding was dependent upon the answers that were given there, would pay attention differently. This is part of what I'm talking about in terms of how do you use rules, regulations, policies across organizations to have them move in a direction that is towards diversity and inclusion. How can we be more creative so that we're not standing in the door going, please, 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 but we're actually changing how business gets done. Thank you very much.
Thank you.